Welcome to Parallax by Ankur, a podcast produced by Radcliffe Cardiology to bring you a new angle of all things cardiology and the best from the US Cardiology Review. Published every second Monday, Ankur Kalra, MD, interventional cardiologist at the Cleveland Clinic in Ohio, USA, speaks with legendary cardiologists, reviews late-breaking trials, and interviews authors of our latest and best US Cardiology Review articles. We call them #audio articles. Parallax is the effect whereby the position or direction of an object appears to differ when viewed from different positions. So this podcast is your fix of reliable updates on all things cardiology by someone from a non-traditional background who is always looking at the industry from a new angle. Now, here's your host, Ankur Kalra, MD.
Hello and welcome to Parallax by Ankur Kalra, a podcast brought to you by Radcliffe Cardiology. Radcliffe Cardiology is a medical media company publishing 6 peer-reviewed medical review journals on general cardiology, interventional cardiology, arrhythmias and electrophysiology, cardiac failure, and vascular and endovascular surgery. Radcliffe also hosts monthly educational webinars and roundtables and produces regular expert interviews on the latest research and devices in the cardiology field. All of this is available on Radcliffe's website for free. My name is Ankur Kalra, and I'm the host of Parallax, Radcliffe Cardiology's first ever podcast. I'm the editor-in-chief of US Cardiology Review, a bi-yearly peer-reviewed cardiology journal published by Radcliffe. I am an interventional cardiologist with a focus on coronary and structural heart interventions. I'm based at the Department of Cardiovascular Medicine at the Heart and Vascular Institute at Cleveland Clinic in Cleveland, Ohio. I'm also an assistant professor of medicine at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. The purpose of this podcast is to bring the great content published by US Cardiology Review in a new format. Each episode, I will be interviewing one of the authors of an article published in the most recent US Cardiology Review, so that you don't have to read the article, but can listen to it on the go. Think of it as an audio article. The past 2 weeks, I've also been traveling through my home country, India, on the Cardiovascular Science India Tour 2019. More on the Cardiovascular Science India Tour 2019 in an upcoming issue of US Cardiology Review, which will focus on the scourge of coronary disease in South Asians, and what I and the editors of the journal Circulation learned during our tour to India in March 2019. By the way, do check out the upcoming late-breaking trial that will be presented by Dr. Jagmeet Singh of Massachusetts General Hospital and Harvard Medical School at the Heart Rhythm Society meeting in May 2019 on the effect of cardiac resynchronization therapy in patients with chemotherapy-induced cardiomyopathy. In episode 2, I'm speaking to Dr. Santiago Garcia of the Minneapolis Heart Institute, who published an article on high-sensitivity cardiac troponin and their role in acute coronary syndrome. In US Cardiology Review, Volume 13, Issue 1, published in March 2019. You can find the full link to the article in the podcast's show notes. We have with us an esteemed guest. I have the honor and the privilege of introducing our listeners to Dr. Santiago Garcia. I met Santiago as a fellow in Minneapolis when I was training at the Minneapolis Heart Institute. So I consider him as my teacher, my mentor, and my friend. Dr. Garcia is Associate Professor of Medicine at University of Minnesota. He is an interventional cardiologist at the Minneapolis Heart Institute. Santiago, welcome.
Thank you. Thank you so much, Ankur, for the kind introduction, and it's a pleasure for me to be here today.
Thanks, Santiago. So I also want to thank you for your contribution to our journal with an excellent article, which I think holds a lot of relevance in the daily bread and butter cardiology that all of us practice every day. The article is titled Role of High-Sensitivity Cardiac Troponin in Acute Coronary Syndrome. And I want to start by asking you just to go over with our listeners some common definitions, which I don't think are discussed, and there's a lot of ambiguity in how people understand these definitions. And I think it'll be important for all of us to be on the same page. So if we could talk a little bit about the following terms, and I'm going to enlist these terms: coefficient of variation, limit of blank, a limit of detection, a limit of quantification, and delta. I think these are very ambiguous terms to people out in the community who practice cardiology. And I think these are concepts or terms which are very important for the general practitioner to understand. So, if you can just take the time and go over with us what these terms mean and how you understand them and interpret them and how you utilize them in your daily practice.
Yeah. Let me start by saying that I'm not a biochemist. I'm an interventional cardiologist. So I think it's important that we understand some of these concepts so we can practice medicine, not so much because we need to understand the granularity of each specific assay. But I think the main difference with the previous troponin assays is that now you can quantify troponin in over 50% of the population using these high sensitivity assays. So the troponin that we're measuring is actually the same as we're measuring before. It's just that we have a more sensitive tool. So it's important now to understand that the troponin positive becomes an obsolete concept in the era of high sensitivity troponin. So to answer your question specifically, the limit of blank really refers to the background noise that is present in the analytical measurement when there is no troponin. So a test that could be positive when there is really no troponin in the system. And that really it should be viewed, I think, as many interventional cardiologists in simple terms will see that as a false positive test. The limit of detection is the lowest concentration that is detectable in 95% of measurements. So usually at this level, which is very, very low troponin concentrations, the imprecision of most assays continues to be high. Therefore, the measurements tend to be inaccurate. The next concept, if we're moving up in the concentration of troponin, is the limit of quantification. This is what most labs consider they can report reliably with a number when there is at least less than 20% imprecision. And finally, the coefficient of variation. This is something that is considered part of the definition when a new test comes out and it wants to be labeled as a high sensitivity assay. It has to have at least 10 or less percent variation at the 99th percentile upper reference limit for that particular assay. So in the old days, troponins had more than 20% variation at the 99th percentile. And this is the cutoff that we use in clinical practice to rule in and rule out people. So now having a less than 10% coefficient of variation, I think, increase our precision. And that's how I see this parameter. It's a way to essentially be more precise. The concept of delta, I think, is tied to the first thing that I mentioned, which is now we can measure troponins in over 50% of the population. So in our minds, we are used to dichotomizing patients as being troponin positive and troponin negative. And now with these assays, that concept is going to go away. What is more important is not so much whether you can measure the troponin, it's what is the delta, how quickly that first assay increase, and whether that has been validated as an important signal for detecting myocardial injury. And we can go into the details as to what is a delta of clinical significance. Both absolute deltas and relative deltas have been validated in clinical practice, and I think most of the experts will favor absolute changes over relative changes to define ongoing myocardial ischemia.
Great. I think it'll be important for our listeners to delve, a little bit more into these concepts that you just touched, because I think these are such important concepts, particularly for physicians in the emergency department, who I think are the first responders, if you will, for taking care of these patients. I think if you can just go over, the absolute delta and the relative delta, I think those are very important concepts. As much as they are for me, I think they're going to be important for everyone in the community.
Yeah, so the relative delta refers to really how much of that second troponin value is an increase in expressed in percentage in comparison to the first value. So if your first value is 10, your second value is 20, that's a 100% increase. And each assay has a different level that has been validated in clinical practice. So there's no number that one can remember. It's just have to be familiar with the one that your hospital is using. The absolute delta, I think, is the one concept that I think most experts would agree is perhaps more important than the relative delta, and that is the absolute number that has been validated with clinical events. For example, for the high sensitivity troponin T, it's 14. For troponin I, it is 26. So a value less than that, it has a very good negative predictive value for myocardial infarction. And these are now part of the rule-out protocols, which, in general terms, perhaps we should tell our listeners that there are really three categories of accelerated diagnostic protocols. The first one is the one that just takes into account the troponin values. And there are, I think, a number of tests now approved in the United States, I think up to 4 now, but there will be more coming. And each one has its own specific criteria for positivity. The second type of accelerated diagnostic protocol, it's a combination of troponins and risk scores. And these have been validated in clinical practice, where you can use specific troponin plus the TIMI risk score, or the ADAPT score, the HEART score. There are multiple algorithms out there, and in general, what it does is improves the diagnostic accuracy of the protocol when you combine clinical variables with laboratory parameters. And the third one, which is one that is interesting because it won't be available, I think, in the US for a while, is the single blood test. When you can come into the emergency department and do one test, in particular in patients that have had symptoms beyond 3 hours, and then you have the ability to send the patients home with just one high sensitivity troponin measurement. And there are different values that have been validated. For troponin T is 5, has a very high negative predictive value. For troponin I, the architect test is 1.2 nanograms per liter that has a 99% sensitivity for acute myocardial infarction. The problem is that in the United States, the FDA has approved the use of high sensitivity troponins, but has restricted the reporting of results to concentrations that are at least 6 nanograms per liter. So anything below that, you won't get a number. And therefore, I guess the mandate is there that you probably need to do more than one test. You have to do one of these rapid rule-out ruling protocols that involves serial testing. Usually, at time 0 and 2 hours, or time 0 and 3 hours, depending on the test. There are also super accelerated pathways where you test at 0 and 1 hour. And there are different cutoffs for all these different algorithms.
Thank you for touching on the protocol, Santiago, because that's a great segue into my next question, because I was going to ask you the protocol that you use in your practice. And, I think, again, for the listeners, I think it'll be important to delve into the details or the specifics of whether it's 1 hour or 2 hour algorithms that you use at the Minneapolis Heart Institute.
Well, surprisingly enough, we haven't yet fully embraced high sensitivity troponins in our hospital. We're making the transition in that direction. So I can't speak for our own experience at the moment, but what I would say to the listeners is all these protocols have been extensively validated. Whether you do 0 to 1, 0 to 2, and 0 to 3 hours, it really depends on the assay you're using and the level of confidence you want to have. But in general terms, these protocols have very, very high sensitivity and specificity. We're talking about the order of 96, 98% for specificity for myocardial infarction. And the predictive value of these protocols tends to be in the order of 72 to about 85% or so. So they're all fairly similar. I think the one variable that is important is the duration of symptoms. So if patients present with symptoms for over 3 hours, I think the sampling interval is perhaps less important. If patients present, within 3 hours of having symptoms, then these different pathways may have some very subtle differences. But overall, I think the diagnostic accuracy is very high for all of them.
So that leads me to my next question about differentiating type 1 versus other types of myocardial injury. What is the first diagnostic downstream test of choice you deploy or use when you have a positive high sensitivity troponin value?
Yeah, so I think it's important that to understand that a positive troponin does not necessarily equate myocardial ischemia due to atherosclerosis. There are other causes of positive troponin. The most common ones in clinical practice involve chronic kidney disease, congestive heart failure, etc. But the clinical correlate of myocardial ischemia is an important consideration in the definition of myocardial infarction. And that's something that has been maintained over the years, even though the definition has changed a little bit. To have a clinical correlate of ischemia is very important. So I do think that there is a role for a good history and physical when trying to distinguish type 1 versus type 2. Many times we are checking troponins in patients that are asymptomatic or have no indication of angina. The typical example that comes to mind is someone in the perioperative setting. Many of these patients are recovering from anesthesia. They won't report angina. They may or may not have EKG changes, but they will have elevation in cardiac troponins. So it's very, very important to understand the syndrome here, not to pull the trigger for all these interventions that usually come when someone makes a diagnosis of myocardial infarction, because our understanding of this entity is still very limited. So I don't have a gold standard for diagnosing type 2 myocardial infarction, but I think it's a combination of a good clinical history. I don't have an absolute value of troponin that makes me think type 1 versus type 2, because I've actually seen very high troponins with type 2 myocardial infarction. What is important, and I think the driving force is what's the pathophysiology? Because seeing the tachycardia, segment depression in someone who just lost 3 units of blood and is recovering from a AAA operation, I would be more inclined to think a type 2. At the end, I do think it's a combination of all those variables and coronary angiography. That's really the best way to understand the pathophysiology. I'm not suggesting that everyone with type 2 should get a coronary angiogram, but I think without that, it's difficult to understand sometimes these two entities.
Sure. Is there a threshold where you would consider a test in between, for example, a coronary CT angiogram and not an invasive coronary angiogram, to sort of utilize that test as a gatekeeper to invasive angiography? Or is it that it's very dependent on history and physical and not particularly the absolute troponin value for you to consider that testing, that intermediate testing in between?
Yeah, I think that the role of non-invasive CT in patients that have elevated troponins has not been fully investigated. In general, those patients, when we want to define the anatomy, we tend to take them to the cath lab. I do think there is a role for MRI in understanding the pathophysiology, perhaps in some of these cases, and echo obviously as the first step. So my approach has been when I'm thinking in a type 2 myocardial infarction in a patient that has medical illness, whether it's the postoperative setting, ICU patient, etc. We generally start with an echo, an echocardiogram, and unless there is high-risk features there, such as multiple motion abnormalities, low ejection fraction, etc., I do not offer coronary angiography immediately to these patients. We like to see them at 30 days. They get started on optimal medical therapy. Usually that means aspirin, if they can tolerate that, beta blockers, ACE, and statins. And then we see them at 30 days, usually with a functional test, and see how they're doing. And in general, they are doing much better. This is not something that they present with angina 30 days later. In general, the patients, once the medical illness is resolved, they tend to do well. And at 30 days, we do a functional test to risk stratify the need for coronary angiography. The patients that we like to take to the cath lab immediately are the ones that are hemodynamically unstable, the ones that have more dramatic EKG changes that suggest high-risk coronary anatomy, ST depression in multiple leads, or ST elevation that is transient, or troponin values that make the consulting cardiologist uncomfortable. And that really has different thresholds depending on who is doing the consult. I must admit that there is a fair amount of clinical variability in that. But in general, any troponin that does not start with a 0 gets my attention. Any troponin about 1, I think it's something that I at least spend some time looking at the echo, the EKG, and trying to understand what the pathophysiology may be.
Great. And then I think we should also talk about the intermediate gray zone. There is a section in the article, and I would really encourage the listeners to actually, I think the podcast is great, and I think it covers most of the concepts that Santiago has written about, but I think it's good to go back and read the article that Santiago and Mahesh have written. Would you be kind enough in just touching a little bit upon the intermediate gray zone for the troponin assays?
Yeah, so this is, in simple terms, is when your clinical judgment and your troponins don't go together. So you have a strong reason to think the patient is having an ACS. However, the troponin values are telling you the contrary, that this is not something that you should worry about. And the guidelines, and I think we mentioned this in the paper, the European guidelines make a specific recommendation to use clinical judgment. And in those patients, really that involves usually reviewing medical records, performing serial EKGs, doing a more prolonged sampling interval so that we don't miss these patients. Using clinical scores, such as the heart score, is also useful, so then you can reclassify this gray zone patient as low, intermediate, or high risk. And I do think, and this is not something that at this point is supported by the literature, but that would be really a nice role for cardiac CT, because that's a test that has been validated in the emergency department setting. And I think it's simple and available enough in 2019 that can eliminate the uncertainty around this diagnosis in these patients that do not fit criteria for myocardial infarction, but higher predicted probability of having disease.
Great. And then Santiago, as my concluding question is, as someone who's obviously seen this field evolve, and I obviously consider you as an expert in the field, where do you see this going? Once the high sensitivity troponin assays are introduced into clinical practice, do you foresee an interim increase in downstream testing when it comes to invasive angiography, or certain selective invasive strategies, or certain tests like the cardiac CT or the cardiac MRI, or myocardial perfusion stress imaging? where do you see resource utilization going, once the high sensitivity assays are introduced in clinical practice?
I think some of the consequences of introducing these assays in clinical practice are easy to predict. Others are not so easy to predict. The one that I think is fairly straightforward to predict is we're going to see more patients going home with reduced or accelerated chest pain pathways, where they can get ruled out very quickly in a couple of hours and go home safely. And that, I think, is going to be a plus of having these assays available. The one part that is the one you alluding to in your question is more difficult to predict is how physicians are going to adapt to this. Are they going to order more tests? Are they going to be taking more patients to the cath lab? I think the experts, they all strongly advocate that this transition to high sensitivity troponin should not occur without preparation and intensive education. The concern here is that people will think that any positive troponin needs to go to the cath lab. When in reality, that's part of the definition of high sensitive troponin, is that you can measure these values that we could not measure before in over 50% of the population. So that would be, I think, a very serious mistake. I think once you have adequate training, I don't anticipate that this will cause a significant increase in the number of invasive procedures being performed to these patients. It shouldn't. But really the key word here is education and preparation, because we have to change our mindset. For many years, we were told that circulating troponins are not normal, and that when they can be detected in the bloodstream, they indicate myocardial damage. Well, that concept is going to have to go away. We're going to have to start focusing more on deltas and what deltas have been reported to be of clinical importance and what are the deltas that we can ignore. So people walk around with detectable troponins, and we need to understand that as cardiologists so that we don't inflict damage by doing the necessary procedures.
Great. This has been an excellent summary of an article which is very well put together. Santiago, thank you once again for joining us. I think this is going to be very meaningful for our listeners and for clinicians who are taking care of patients in the trenches. It's a very meaningful summary. It's a very succinct summary of a very important topic. So I thank you once again for your contribution.
It's been my pleasure, and thank you for the opportunity.
If you have any questions or comments about this audio article, thoughts on the Cardiovascular Science India Tour 2019, or the upcoming Made It Chick trial, the Jagmeet Singh trial that will be presented at HRS 2019, please send this through to us at podcast@radcliffe-group.com, and we will share this with audience in the next episode. Thank you for listening to Parallax, brought to you by Radcliffe Cardiology. My name is Ankur Kalra, and I look forward to joining us again for our next episode on early management of benign essential hypertension by Dr. Athena Pappas. Dr. Pappas is the current Vice President of the American College of Cardiology and Chief of Cardiology at the Department of Cardiovascular Medicine at the Warren Alpert School of Medicine of Brown University. Goodbye for now, and speak to you again soon. Thank you very much for listening.
Dear cardiologists, we want to make this podcast about you and for you. So please email us your critical thoughts, comments and questions at podcast@radcliffe-group.com and visit uscjournal.com for more information. You can also follow us on Twitter, LinkedIn, Facebook and Instagram at Radcliffe Cardiology for daily updates. Join thousands of cardiologists and become a Radcliffean by registering to radcliffecardiology.com. You will receive regular newsletters and gain access to hundreds of expert interviews, educational webinars, clinical cases, and peer-reviewed articles from our 6 medical review journals on general cardiology, interventional cardiology, arrhythmia and electrophysiology, cardiac failure, and vascular and endovascular surgery. Thank you.